Good afternoon, everyone. Thank you for attending the kickoff presentation for the 2024-2025 Oregon Bioethics and Humanities Colloquium Lecture Series. I'm Prasanna Krishnasamy. I'm the Medical Director of Clinical Ethics at Legacy Health. I'm one of the co-chairs for this year, along with Dr. Iran Klein, who's an Associate Professor of Neurology at OBHC and a staff neurologist at the VA, in addition to being an affiliate assistant professor at the Department of Philosophy at the University of Washington. A little bit about the OBHC series. It's a 7-part endowed series that creates a space for thought-provoking discussion and exploration into complex bioethical issues that revolve around philosophy, humanities, policy, and cutting-edge research. OBHC aims to create an environment that fosters critical examination of the human experience and seeks to provide new, innovative perspectives that will challenge all who attend. We have a special guest speaker today, Dr. Paul Ford from the Cleveland Clinic. He is currently the director of the NeuroEthics program at the clinic. He is also a member of the Center for Bioethics there and has secondary appointments in neurology and the Center for Neurological Restoration. He received his BA in Computer Science and Humanities and BS in Mathematics from Walla Walla University. Subsequently, he received a PhD in Philosophy from Vanderbilt University, where he participated in a 2-year Transplantation Ethics Fellowship at the Vanderbilt University Medical Center. He's been active in ethics consultation since arriving at the Cleveland Clinic in 2001 and has performed approximately 1,600 clinical ethics consultations. In fact, when I was new to clinical ethics, I spent some time at the clinic, and with gratitude, I want to share that he taught me very well. He holds an appointment of Associate Professor at the Cleveland Clinic Lerner College of Medicine. He actively teaches medical students, residents, and fellows. His primary research interests focus on ethical issues raised by neurosurgical interventions, such as deep brain stimulation and epilepsy surgery. He has co-edited 2 books and is the author of more than 70 publications. He lectures nationally and internationally on a range of issues that include neuroethics, clinical ethics consultation, transplantation ethics, and engineering computer ethics. Please join me in welcoming Dr. Paul Ford.
So really a delight to be here and talk with you. I know there are people online, and at the end, if you have questions online and you want to unmute and ask them, please feel free. If you see something during my presentation in person here that you want to push back on or interrupt me, I'd rather have a good conversation and have dynamic and fulfill the needs of the audience than get through all my slides. So I tend to be a nervous person, so I have enough slides that I know I can I won't fall short. And it turns out there's enough stories as I was thinking about the cases that also, but if you have a pressing question, you think now's the time to ask it, raise your hand and I will stop and we can talk. So please be assured that I do appreciate that kind of conversation. I'm happy to be back in the Northwest. My college years in Walla Walla, Washington were good years, and I've always enjoyed the culture. Firm believer in starting out with cases as a hook. So you think about this this patient who, 45-year-old, gets presented at a surgery selection committee meeting, medically refractory seizures for decades. It's known and described during the meeting that after a seizure in the postictal stage, he often is confused and often becomes very violent. And in fact, as a result of this, he has spent considerable time in jail over the years, and with assault charges and others. So these are not thrashing his arms around, but these are pretty violent instances. During the selection committee, they say, we really need to get a full surgical workup in the epilepsy monitoring unit, which of course means 5 to 7 days, reducing medicines, and we're going to let him seize. And when he seizes, he has a postictal phase. So we know that. There's good international guidelines that say it's a bad idea and against recommendations for people with motor seizures to be restrained in physical restraints. And we know that a lot of the sedating medicines will also potentially suppress seizures when we're trying to allow them to seize. Okay, so you see where we're hitting a dilemma. Is it ethically supportable to admit this patient to the unit? And of course, the more interesting question often to me is, if it were, what would the conditions need to be, right? What is, because it's not so binary as ethical, unethical. It is, yeah, if you're going to do one or the other, how are you going to do it? Because it's in the how, the reasons why. What are the values at stake? You'll hear me talk a lot about values. What harms, benefits? And when I talk about values, I always talk about what we're going to sacrifice. So think about that. We'll come back to it. So thank you for the lovely introduction, Prasanna. Very much appreciated your work when you came to the clinic. I've worked with Aaron Klein over the years, off and on with projects. We have a new volume of Cases That Haunt Us coming out that Heidi Funk has contributed a lovely chapter that very much appreciate her reflections. So you'll see that come out. So I'm now up well over 2,000 consults. I need to update that web page. Doing it about 25 years. We do inpatient and outpatient consults. Most of the time it's face-to-face at bedside, doing rounds, being part of the clinical team. And Prasanna nicely highlighted, I had a chance to meet with him earlier, that although it may seem like I just do a single ethics consultant model, he made me realize that I really have a stair-stepped approach that is a variety of models. The simplest is a single consultant on the telephone, simple question, and then there are those other ones where we come in complicated cases as a team member of the treating team and others. But then there's those rare cases, and I'll talk about one of those at the end, where we then escalate that, not just the team that's involved, we now get people involved in higher and higher levels of administration. So I don't act as a lone wolf, I act as a ethicist embedded in getting the multidisciplinary perspectives of all the caregivers, family members, and patient. And when I say family members, I think very inclusively. Those that are important relationally to the patient. I don't care whether it's by blood or marriage or friendship or whatever they're. So just put a marker in there. When I say family, it's an easy way for me to refer to people that are important to the patient. Lots of stuff in neuro that I do. For this talk, I've focused many of them on epilepsy. So I have, for the last 20 plus years, have been part of the patient selection committee that meets weekly for the epilepsy surgery team. We have one of the oldest and highest volumes epilepsy surgery programs in the country. I've also been involved in deep brain stimulation committee meetings since it's moved from research to clinical practice. So examples will be largely drawn from those, although I have a broad experience in clinical ethics. And I think the last point is just simply that, no matter what our venue is, I was in Toronto last week, whether it be Cleveland or Portland, there's something that connects us, I believe, as humans, that many of our problems are very similar. They may have different language around them, but at core, often we have similar kinds of challenges. Oh, and I have a little maple leaf at the bottom because you'll hear me say the word out and about, and not to let you distract you, but I still haven't lost my Canadian accent after all these 30 plus years. So CME always requires objectives. I'm going to talk about identifying ethical dilemmas in the context of brain surgery evaluations. It seemed like a vehicle we could get at some of these interesting questions. Of course, we're going to analyze lost and preserved values and approaches to resolving dilemmas. And it's always about justifying one course over another, how one is more ethically acceptable than other because of the sacrifice is in some way judged to be more acceptable. So I have a variety of cases, but as a mechanism to do this, you've already seen one of them. I list out sort of a kind of list of at least 5 that I think are particularly interesting. And there's another couple blended in there. And the idea is that I want to highlight the values at stake, gives lessons learned approaches, and also be thinking, is there a similar kind of case or a case in your practice that you'd want to share just a couple of lines about and then reflect on what your lessons learned are. I'm happy to take away some of your knowledge from this session and hear your advice. So when you think about at the end and when we open up the mic, particularly I often say, what are the values? Who could lose out? The best example always, I think, is transplantation. If you have a heart transplant program, and if you sometimes would add something like a little bit of an inotrope that they may not actually need, you can get them higher in the list. It may seem like your institution wins, the patient wins, the life saved, but you may not be accounting for the person who didn't get the heart at another institution as the person who's out. So always ask yourself, who is losing out? Because if it seems like it's a win-win, either it wasn't a dilemma, or you're just not paying attention to what's lost or who's losing it. One or the other. So I already mentioned cases that haunt us, and growing up, I spent many summers in mid-northern Ontario that had loons, and loons at the mist. I saw on your trolley, tram, sky, what is it called? Tram. That this morning there was like a cloud cover mist that was a little bit haunting. When you hear loons at the on a lake in Minnesota or Ontario, there's something in your gut. So we all have these cases, whether we're ethicists or physicians, that sort of stick with us, and you wonder, we want to avoid another Sarah or Mr. Smith, and these things I think are important for us to learn from and think about how we could do them differently in the future. And I'm a big fan that it's not enough to have gut feeling, it feels viscerally wrong to do this. We need good reasons, and we need to have analysis and synthesis in order to do so. So this is what I take to be at the core of ethics consultation and the values that the challenges that we face. Is that for me, I don't go with 4 principles or boxes. I get to the specification in regular language right away, right? Because if you say autonomy, I don't know what you're talking about. You say I don't want to restrain a person because I don't want to take away their right to move around. I understand you. So I throw up a few things: safety, integrity, health, lots of different axes on which we have things that are important to us. But by values, I just mean, what are the things that we don't want to lose out on and that we want to preserve, right? In just everyday language. And there are wrong choices, right? And usually I only need to say that to the sort of undergraduate audiences that say, oh, well, you believe what you believe, I believe what I believe, and it's all relative. And that's fine as long as we're not interacting with one another. But once we interact with one another, there are some things that are clearly wrong. If I want to harm persona for no reason but my own enjoyment, everybody's going to say, that's wrong, we're not even going to think about it. Most of our time is spent on the gray. That's why we think that so much is gray. But in reality, there are wrong choices. And as ethicists, we can often eliminate them quickly. We're not going to lie to the patient because there's no justification in this case, right? And we move on. So I thought I added the slide of the word about, oftentimes in surgical selection, people call them patient management conferences or patient selection conferences. So if you hear me say the PMC, it's patient management conference, particularly for epilepsy, an epilepsy patient management conference, they're really looking for the ideal candidate of somebody who had a focal seizure that is seen on MRI, that has an ictal speck that lights up when they seize, and that their semiology on the video EEG that they have all matches and in the temporal lobe, right? And those ideal cases, you seizure-free, 80% of population be seizure-free at year 1, 60% by year 5. Right? So again, when I talk about epilepsy surgery, none of these are a sure deal, even the best scenario. And then the PMC often deals with all of the other kinds of ways in which epilepsies, plural, occur. Because epilepsy, it turns out, is a description of the event or a wave pattern. It's not the underlying reason. So there's lots of different kinds of epilepsy. And then the other thing I'll talk about is invasive monitoring. They used to open up the skull and put grids and depths, or grids on top of the brain and the depths. That's done relatively rarely now. Most often it's more like a deep brain stimulator lead that's drilled with little twists, anywhere from 4 to 64 of them. And then they take them back to the epilepsy monitoring unit, let them seize. So sometimes the video EEG isn't enough. So they have to decide whether they're going to do an invasive procedure that has a risk of bleeding. And so that's another point that's important to understand. And so all of these things are to the end of saying, can we do, when your epilepsy medicines have failed, can we do something to help your seizures? And these interventions range from a small laser ablation to a full cortical hemisphere removed. And it's actually quite remarkable when the clinicians will point to me to a kid that has some braces on but walking and talking and say that kid had half of his cortical hemisphere, had a cortical hemisphere removed, right? So it's remarkable how big changes can have lesser effects, and sometimes small little infarcts can have big effects. And that's what's intriguing about the brain, is that sometimes it's about real estate, sometimes it's about the timing of when injury happens. So the most common would be a temporal lobe resection, and with later you'll hear more about the hippocampus. They found early on that you can't remove both hippocampus on both sides, or you don't generally be able to encode new memories for the most part. And then there's the laser ultrasound, high frequency ultrasound open. And then also, just like deep brain stimulation is used for movement disorders, Parkinson's, there's various stimulators that can be used for epilepsy. Okay, so that's my crash course in 2 minutes on epilepsy surgery selection committees, to give you a context of again, that, in fact, first case. So back to the balancing. I take most ethics work to be balancing of values and sacrificing one for another, right? And I give you quick 3 examples, rapid fire here. You think about a surgery to eliminate seizures, but it's close to the eloquent cortex for language. We've agreed that it is unethical and not medically indicated to eliminate seizures at the cost of making someone completely aphasic, right? Somebody who's expressive and receptively aphasic, we're not going to do that. But as it gets closer to the language, how much, if we value speaking as social individuals, understanding formal language, how do we understand whether we're going to risk that and which we're willing to sacrifice? You think about uncontrolled seizures in an adult who is transporting their kid to school. What's your tolerance for calling Child Protective Services? When is it a reasonable suspicion if they say, well, I've never had a seizure while I'm driving, and yeah, I haven't reported, so I haven't lost my license, and the only way they can get to school is me driving them, otherwise I'm going to lose my kid and can't get them to school. Right? You want to have trust with the patient. You want to protect that vulnerable kid. You have a legal obligation. You want to still be able to see the patient to benefit them. Lots of things at stake in the values. And then finally, the example I give there is you think about all of the trouble and difficulty in doing a randomized clinical trial, when sometimes you just want to do something off-label, right? You want to gain knowledge, but you also want to help this individual patient. These are the kinds of things that I mean about balancing. And I had a person wrongly quote Emerson. They left out the word foolish. So I was on an IRB and I said, last week we decided a very similar protocol. We need to do the same. They said, oh, consistency is the hobgoblin of small minds. And I was so, I'm anxious for somebody to misquote this, please, to me, so I can throw this out to them. They said, it's a foolish consistency. And this is where, if you're going to make a different decision, you need to have reasons, right? We ought to be consistent PMC to PMC, week to week, and this is sort of my ethical underpinnings. Okay, so I give you a sense of what I mean by ethics. So I want to give you a common, it may be not your common platform, but give you a sense of where I'm coming. So let's come back to this. So we have that 45-year-old, becomes postictally violent, assault charges. The team said he's, kind of scary, and the nurses are anxious and don't really want him on the unit. They're afraid for their safety, and we know that restraints can be dangerous. So they had me meet with this patient. it was really funny. He was rough around the edges. His education had been limited by his medical condition, and he had plenty of ink. And in Cleveland, that has more stigma than here in Portland. Still a little more conservative. But the first thing out of his mouth, as I introduced that I help with decisions and want to have the right process, and we're worried about his postictal state, first thing he said to me was that I don't want to hurt any of those nice nurses. They're just trying to help me. All these nurses, and I said, I'd feel just so bad if these people are trying to help me, if I hit them, but I don't know what I'm doing. I find out later, and I see a video, and I say, it's not me, but what can we do to so I can maybe get this surgery because medicines aren't helping? He knew that it was less than a 1% chance for a new medicine to help him. And if he had a 60 or 70 or 80% chance of reducing seizures or maybe being seizure-free, I'll do the surgery if they can find that I'm a good candidate, but how do I not help? We talked it through, and we want to keep patients safe and we want to keep providers safe. We couldn't do that perfectly. But he was volunteering to be sedated, to be tied down. And so our obligation was to figure out where was that balance, and we didn't have to take the step. It was a more difficult step if we had to say, if he said, I won't be restrained, but I still want the evaluation, how to keep him safe. But in that case, the team's assumption that he didn't care whether he hurt somebody was just wrong. Right? And so part of that lesson was make sure that we ask the person what's important to them, because sometimes it'll align. And ended up, we had a plan to have loose restraints, and he was willing to take that risk because of his value of not wanting to hurt other people. And the nurses were willing to have the loose restraints, even though he probably could still hit them. And so we found a balance, but recognizing that something was sacrificed. So I'm going to go on with the postictal memory. And I couldn't find a nice MRI quickly with the hippocampus. So, the neurologists always love to talk about it as a seahorse. And it's the one structure I can reliably see in a brain when they go through the MRI. I can now pick out where the hippocampus is. I see it so often, So not only is postictally people can confuse violent, but they very frequently forget what happens, right? And so now many of you may be familiar with status epilepticus, because people end up in the ICU with continuous seizures that, within a minute occur again. But there's also something called subclinical status, which means they don't outwardly show that they're seizing, but they have either an absence or some kind of thing. So we had this guy that was capacitated, living on his own and getting by. Seizures were not well controlled. But the neurologist and surgeon called me up and said, well, how can I be sure I'm getting good informed consent? Because I can't tell whether he's seizing right then, and then he won't remember, right? So he doesn't need a guardian, does he? He said, maybe we should get guardianship. And I said, you're going to take away a lot of rights. What can we do? And I said, well, there must be a good process. Right? And over the years, I've been much more firmly engaged in this idea of supportive decision making. Right? I pulled up. I love the form. If you look on Alberta, Canada the government has a nice form to actually formalize the supported decision maker. Someone who you're capacitated enough to know who you want to make your decision, not just an advance directive. But this was a perfect place for me to say, listen, he's an adult, but his mother comes to every visit with him. He trusts her. And do you think that he would trust if his mother said, yeah, the surgeon told you that, you just must have forgotten whether they said yes? I said, well, get him to sign it. And she's really next of kin in the Ohio hierarchy. Put a note that she agrees to. And then even if someone comes back and says he wasn't capacitated, then you still legally have the person that would be next in line to agree. But more importantly, you've maintained trust with your patient. You can say, I know you don't think I told you that, but you and I agreed that your mother was going to be your support. Ask her whether she remembers. And this kind of process works very well. And patients actually appreciate it. You get some people who are fiercely independent and don't want anyone, and you don't force them. But the shared decision making, I more and more think is the best way. And we don't have a formal law in Ohio for shared decision making. I didn't get a chance to see in Oregon. You tend to be a little more progressive than Ohio, but as a stopgap between partial guardianship and this. So again, another case, I remember I told you that SEEG is the implanted devices that they then, if they haven't been able to, the video EEG doesn't localize it as well, or it's very close to a eloquent cortex, they'll then put a whole bunch of DBS-like leads, put them back in the unit. And sometimes they don't think that the seizures are focal, or maybe there could be two foci, but it might spread fast, so it might be one. Or so here you have an 18-year-old getting ready to go to college, and in this case, it was about in June that this case came up. Really wanted to go to college, and would like to have a normal life. And it's important that uncontrolled, but only one seizure a week, and they're not one seizure a week, and they don't cause falls or drop attacks. He has some recovery needed. I was going to say not life-threatening, but we know that uncontrolled seizures have a real mortality risk of up to 5% per year, 4% per year, of all comers. But that includes drowning, sudden unexpected death, car accidents, that is higher than a general population. So wants a community, going to community college, and wants a normal life. So they don't have a really good hypothesis, but they think maybe there is a chance of tailoring a surgery that will help this young person. And but it's unlikely this is going to be scheduled quickly. And even the intervention is close enough to eloquent cortex that he's going to lose some memory function. So what kind of values would you have in consideration offering counseling to this patient, that of whether to have the SEEG, and particularly for timing? Because remember, these are elective surgeries. This kid's had seizures for 14 years. So it doesn't have to be done, but it's medically indicated. So it's not a frivolous thing. What are some of the considerations that you might think about if you were the ethicist going to talk with this patient? Please.
So how would you concern that and just ability to get quite possibly anti-tags and seizures and again, understanding that people behavior from a maturational standpoint?
So lovely, lovely comment. And again, from a pediatrician's viewpoint, and magically 18, suddenly everyone becomes fully aware. Yeah, does he really understand the implications? And there was a big debate within the committee, not about how to give him informed consent, but how to help him navigate the question of, do I get through my college and get needed skills, and my memory will be less important to me because now I've already encoded what I want to train for? Or do I get the surgery now and I'm able to fully embrace the college life? And to an 18-year-old, it's pretty important to stay up late at night and do all kinds of things that are bad for seizures, right? And want to take part in that life. If you believe you're going to take the memory hit, is it better to get it over with and then compensate with it and then try to go to college, or to get your education? Are you going to miss out on this window? And the team was pretty split, even about whether to do the SEEG, because it would be 2 months needing to be scheduled, and that would get into his start of his college. So in some ways, the worst of both worlds. If you were to do the SEEG, have him delay college, he wasn't starting with all his friends, and then you didn't have a surgical option for him anyway. Right? Do you just wait until he has a break? Do you become too paternalistic as an 18-year-old? Do you insist that he has some supported decision-making? Particularly it was a male, so the myelination of the brain in males takes a little longer. At least that's what I think the science says. So this is, it's a hard judgment for anybody to make. And Bob, you made a good point. How do any of us know what it's like to have a little bit of a memory loss? It doesn't sound so bad if the doctor says, well, you might have a little bit of a memory loss. I find it pretty annoying when I can't remember names. Do I find it a whole lot annoying, or I wouldn't notice it because I usually don't remember names, right? So among very thoughtful people, this was a controversy. I mean, it ended up that they were willing to offer this to him, but needed further guidance. I met with this patient, and the pediatric epileptologist also met with the patient. I strongly advocate sometimes for people who either are young like this or perhaps have developmentally haven't matured. So even a 30-year-old who hasn't developmentally matured, maybe limited cognition, to sometimes employ some of the pediatric specialists to in a developmentally appropriate way to explain things. So, I had, in the title, clearly, I felt obligated after I had a bunch of cases, and then I felt obligated because in the title I talked about the split brain. But this is one of the things that we can learn from the corpus callosotomies became very popular in the 40s. After a while, when we got better at imaging and better at resections, they become relatively unheard of through the late 90s and 2000s, and they have a resurgence, but in a very limited way. So the corpus callosotomy is where they split the brain. The corpus callosum, sometimes it's the anterior, sometimes posterior, sometimes it's the entire thing. But it turns out that that you can have some pretty odd and unusual things that at first in the early days weren't noticed, right? And so they did a whole bunch of experiments in the show that if you split the brain and don't let it communicate side to side, and the idea is that particularly for drop attacks, if you can keep the seizure from spreading from one side to the other, that you will keep people from getting injured. So now it's mainly a palliative neurosurgery, and I put at least one article that we discussed with a colleague that it's really odd sometimes to hear how neurosurgery uses palliative, because it's a different way sometimes than sometimes it's only to mean we're not going to cure you perfectly. But I think that the lessons from the corpus callosotomy often is that we need to be careful about people understanding what consequences maybe that aren't clear. This alien hand thing is something you might have, for those of you who are familiar with Oliver Sacks, I'm sure he had an alien hand in there somewhere. But the idea that that your left hand will go and do things without you consciously knowing. And so if you're split brain, usually it would communicate, you'd know that you're unbuttoning your shirt, but in the sense your body knows, but an alien hand. So there's these odd side effects that, particularly for a patient, and I have one particular in mind that was already disoriented somewhat, had some mental health psychiatric challenges, and is already struggling with reality. What kind of effect does it have is now you're disrupting things that somebody that doesn't have those same normal disruptions. What does it mean to their life if you then add in this kind of disruption? Okay, one of the things that has intrigued me for a long time is non-epileptic seizures, right? People used to call them pseudo-seizures. They're real events, and they're real events that are seizures that are not controllable by the patient or not volition. But they're not epilepsy. The lag time between getting a diagnosis for non-epileptic seizures is about 7 years, on which they normally are given many anti-epileptic medicines. And epilepsy monitoring units, anywhere from 20 to 40% at any one time, I think 50% actually, Texas VA had 50% at one point, end up to be non-epileptic seizures, which are thought to be sparked by a psychological stress, some kind of response that is not an epilepsy. Very intractable, even in those who accept their treatment. the best treatment we have is about 50% of cognitive behavioral therapy. And that's of those who accept that this is not epilepsy. There's another whole cohort who go to EMU after EMU after EMU to get evaluated because they're sure there's really something wrong with me. And the answer is there really is something wrong with you. It's just not epilepsy. And there are other ways we can approach this that don't cause you to be put at risk of epilepsy medicines. You know, it's very striking. The disability caused by non-epileptic seizures is greater than that statistically from epilepsy, right? Completely counterintuitive. But these people are refractory to medicines because usually the anti-seizure medicine will work temporarily and then stop. So they go through this series of getting a little bit of function back and then not. So you have to ask yourself often, and these sometimes occur together. So a patient with epilepsy sometimes will also have non-epileptic seizures. And sometimes the trauma of worrying about the epilepsy brings on the non-epileptic seizures. So this becomes a real challenge when I have to meet with a patient that has both symptoms to help them understand which symptoms that the surgery is intended for. Similarly, when I'm meeting with parents of adult children, parents of school-aged children who want their behavior to improve through epilepsy surgery or their memory, and we have to tell them we can, if their seizures are the things that are interfering with their behavior, then we're going to help, but very likely they have other behavioral things that this is not going to do. Both of those instances are cases of setting expectations, and as ethicists, sometimes we can help people to sort of see that the kind of seizure, for instance, that is debilitating, it turns out it's the non-epileptic seizure, so let's get those under control first to see whether then we can control the epilepsy, because we're not going to do epilepsy surgery for non-epileptic seizures because that's not the root cause. And as a side note, I mentioned this is a functional neurological disorder. That's the name for conversion disorder or psychogenic disease. That's the broader one in the DSM-5. But an odd thing as a philosopher, I found that a functional neurosurgeon is very different, that meaning of functional there, than when a neurologist says that's a functional behavior. Functional neurosurgeon deals with anatomic function of the body, and if a neurologist says that's a functional tremor, they mean that is a psychogenic tremor. So functional here means psychogenic. So you have to be really attentive to those things. So it's been fascinating this morning. Turns out in this region, many of you will know a patient that was similar to our patient here that had swallows foreign objects. Did them well. And again, everywhere I go, there's going to be people who swallow foreign objects and come into the emergency department once or twice a month, or in clusters 3 or 4 times in a week, and then you won't see them for 6 months. Or and this isn't the person trying to get out of prison with swallowing razor blades inside elastic bands, right? These are folks who can't control their urge to swallow things. But this patient is one of the ones that we escalated to the very highest level. And this is one that I worry about. And we even had her evaluated at Mass General by paper, because she didn't travel. Because Massachusetts General Hospital has the longest running psychiatric surgery program in the country. Even after the 1977 psychosurgery report, they had a committee. They continue to do it very well, and they published various series, whether it be obsessive compulsive disorder, they had one self-harm and swallowing foreign objects. This was a 30-year-old, past history of post-traumatic stress disorder, also had a personality disorder, which is not a psychiatric diagnosis, but it's what the psychiatrist kept calling it. Sudden uptick, and for almost 3 years she was hospitalized, intermittently. She'd be home overnight, and then she'd come back to the emergency room. Over 100, I didn't get the exact number, I thought it was 116, 118 endoscopies in 3 years. Her longest stretch were 3 weeks, where she got a new puppy, and for 3 weeks she managed to stay out of the hospital during those 3 years. People said, "Can we do anything?" A number of lessons as I thought about these in evaluation for the surgery. I think probably the MGH was right. Just because we could burn a lesion in her amygdala doesn't mean that we should if we don't have enough evidence, if there's enough comorbidities. But I also worry that we exacerbated this condition. Right? In the end, probably too late, 2 years in, we had a special plan just for her, that she would be admitted to the emergency room and then sent right to the MICU, the medical intensive care unit, endoscopy, and get discharged. Right? Because in our first 3-4 months of hospitalization, when she had a guardian, which very interestingly, the county court then took away the guardian because they said they didn't need it. But our nurses were being very empathetic. They would go down and get her cups of coffee at Starbucks, right? Because they felt bad. She'd been in the hospital, had a tragic story. And our psychiatrists, in the end, concluded that maybe we had fed into this cycle. Right? Maybe the thing that 99% of our patients is a kind, compassionate, wonderful thing for building experience was actually harming her. Harming her with love in some ways. And there are those rare cases where maybe tough love is a way to help patients with this type of disorder. And I also found that there was a tendency for upper administration to revert back to this case when they were doing new policies on patients who swallow foreign objects, and to be austere. And it takes some reminding, I think, from ethics to say, this isn't that case, right? This is the odd case that happened in Cleveland, that happened in Portland, right? But the number of cases that are this severe as you had, you shouldn't make policy for those. You should make policies that allow for, if it gets to this extreme way, that you treat it like this. This is a case I presented at the ICCEC, the International Ethics Consultation Conference. Usually for deep brain stimulation, I moved from epilepsy now to movement disorders. But I thought this would be an interesting one just to mention. A patient had an infection in their deep brain stimulator lead. It usually implanted the generator in the chest, tunneled up, and there's 2 leads in the brain, and needed it to be explanted. And I get a call from a neurosurgeon in the pre-op area saying, "Paul, I need you to see a patient." Of course, I said, "Yeah, I can see them as an outpatient next week." And she said, No, you don't understand. I need you to come and see the patient now." Patient saying, "If you have to take the actual electrodes out, I just want to go home and die." Right? And the surgeon then reinterpreted that as, I want to kill myself if I can't get the benefit, the movement benefit. My life was so terrible. She assured him that she could reimplant it after an appropriate way, even if she needed to get it taken out. Discuss with the. So I went to the pre-op area. Ethics, really often we don't have emergency consults. Often my emergency is I forgot to call you. The family meetings now. Can you come? Right. That sort of defines an emergency. But this is one of those emergency. Either he's not going to get a surgery, going to wait another 5 or 6 months and maybe die from infection in the brain. It'll travel, or he gets it and he was put at some risk. And in the end, between the wife and the surgeon, and we convinced him that it was consistent with his values to move forward. He would get the benefit. He agreed, and it felt good to me at the time because I felt like maybe I just helped him overcome some anxiety. Right? Many movement disorders have anxiety as a component of it. So maybe just helped him see his longer-term goal for his shorter-term anxiety. Right? Surgery happened. Saw the surgeon, said, the electrodes had to come out, but after surgery, he said that was okay. We've now rescheduled the reimplantation. Should be 6, 8, 10 weeks. The infection should be cleared enough. And so saw her again, the surgeon, 8 weeks later, and said, guess what, Mr. Smith was coming in for surgery next week, and he took his own life. You know, and I don't usually follow up. This was such a traumatizing incident for the surgeon. And I went back and I thought, did I give bad advice? Did I coerce him to doing something that he didn't really want to do? The kicker was that he was just about to get it reimplanted, right? So I would have thought the real risk was in the first week or two as he continued to have terrible tremors. You know, and I'm haunted perhaps that as a ethics consultant, maybe, please?
I'm just curious, did you do a full suicide assessment with him at that time, or did you get a social worker like that?
So I have a PhD in philosophy background, so I did not do a suicide assessment. Psychiatry did come by and didn't think he was imminently, he had no specific plan. There was no sort of, it was very contingent and vague in that my life won't be worth living if I don't. So the resident on the consult liaison, the psychiatry consult liaison, saw him, didn't see any reason that needed any further safeguards or protections.
And did folks follow up with him in between that event and the surgical replacement to check them on quality of life?
So I keep forgetting that there's online folks also. So did people, the question was, did people follow up on quality of life checks and such? Not as much as I would do, not as much as we did moving forward. But he was connected already with a counselor, his own psychological support that I knew of at the time. The wife said that she would keep him connected. And so the surgical team thought that perhaps it was enough to just send him home with his usual care. And afterwards, he was so okay with it.
Is there a social worker on that? I haven't seen one.
Yeah, so the question is there a social worker at the neurosurgery team? There is not a social worker. There is a psychologist, though, who had seen him pre-op before the DBS was placed, but not at the time of the surgery. I regretted not calling that psychologist who knew the patient. But again, it was in the heat of the moment. It was either lose the OR time, and if it was just a matter of nudging him over some of his anxiety, and it wasn't so explicit to us, I'll kill myself, it was I'll just go home and die, which kind of was a passivity that maybe the infection will just take its course, which a reasonable person could decide that they're not going to allow you to rip something out of their head and that they will just take their chances with IV antibiotics. It won't work. Yeah, no.
I saw that you cited an article earlier about kind of contingent suicidal ideation in college patients, and that's what I do, and we see this a lot. And I guess I would push back and say I think I would have been super hypervigilant in that scenario in terms of following closely to make sure that this didn't shift. So that's, I think it's interesting. And hopefully that's great for your psychologist as well.
And we actually, it's very rare in that team to do an M&M because mortality, morbidity conference, because usually that would just be the surgical team. But our movement disorders and psychology and psychiatry we did an M&M to talk about what are ways we could support differently in the future. And it turned out that other things in his life had been happening that were not about the stimulator that was likely the cause of the.
Yeah, the Parkinson's comes with comorbidity of depression.
Sure.
Yeah.
Yep. So, yeah.
I had a quick question about the case too. Sometimes Parkinson's medications can be associated with impulsiveness and things like that. Was that a consideration when you were assessing risk, or medication compensation after surgery? Did he have an increased medication load that could have exacerbated things?
So all of our patients undergo neuropsychological and testing as well as psychology to look for behavioral things. So he had gone through a battery before his, and that was not one of his known symptoms to be particularly impulsive. But we also know he'd had the stimulator in for a year, 2 years. We know that deep brain stimulation doesn't change the progression of a disease. It helps with symptoms. So it doesn't mean that his impulsivity may not have changed. And I didn't ask the surgeon about the medication, but I'm very confident that the medication was increased again because it was a subthalamic nucleus DBS, and one of the reasons that they do those is that so they can decrease the medicines. But again, it was 9 weeks, 10 weeks, 8 weeks after. It wasn't, so there was follow-up in the usual surgical follow-up in the first few weeks as it got stable, but by that time it would have been stabilized. And they had no signs and no family calling in worried. So oftentimes we worry about that, look to that vigilance.
So knowing, in fact, you just mentioned, knowing that DBS does not slow the progression of the disease, how do you counsel the patients they're going to go through this surgery, this invasive surgery, knowing that it's not going to slow the progression of the disease? So how do you advise them?
So I was a little bit glib with that, saying that we know it doesn't slow it down. Yeah, so some of the studies in the very early intervention suggested maybe that it does, but in the population we implant, we have no evidence to show that it decreases. Okay, so that's part of the counseling when people want to say, well, I want to improve my cognition and I want to, so we see maybe 10% of the people, 5% of the people undergoing the DBS as ethicists to help them balance whether they're willing to sacrifice, potentially in some people who are on the edge of dementia, say, and there could be a memory hit. The surgeons our surgeons are pretty plain about this. And I've heard them have this consent process to say, this is symptom management, right? So they always frame it as, we can likely do as well as you can do on Parkinson's medicine with your best on state. That's what some people do a little better than best on state. But if a great indication is if there's fluctuation, lots of fluctuation, so consistency, that sometimes they'll do a pump instead if they just want consistency. But it's always framed as, this is going to manage the symptoms as well as your best on. And in fact, we can adjust the parameters later that if the stimulation isn't working as well, there's a chance we may be able to continue for a long time. But my colleague and I, and some palliative medicine physicians, wrote a paper on what to do with DBS at end of life in hospice, right? Because even if they're not dying now, these folks are on average 72 when it's put in, and they're going to die of something. What does it mean to be in hospice with a DBS that needs a battery exchange? So these things progress. So I had a few concluding thoughts. That I realize I now have a typo. That should be patience. I think I needed my glasses somehow. So patients can be put at risk to protect themselves. There are times with the guy with postictal violence. We keep patients as safe as we can, but we also need to keep others safe, right? That this is a fine balance. Sometimes we need to be careful with brain interventions. With DBS, as we look at different sites, the CM or other kinds of places, to watch for new kinds of effects that might occur. Sometimes it's not always clear. The bilateral cingulotomy for OCD has some unintended effects later on that they only caught later. The corpus callosotomy, they didn't realize that splitting the brain would have some of these effects. So because there are so many networks that go through these same areas, we need to be careful as we're thinking about the ethical implications of innovation. What are some of the ancillary things that you may not think are related. Here's something I threw in the middle here that just, I don't know how to think about it. Maybe there's no way to think about it, is you get the 17-year-old volleyball player with Erasmussen's encephalitis who is having a rich kind of life, or maybe a 17-year-old, basketball player that only has an occasional seizure, but has lots of life ahead of them, and they have lots of function. And you could hurt one, a motor function or something. And then I meet with these folks who are relatively nonverbal, who still interact and have a narrow band of communication, and that's what their function they have. In some ways, I would do everything to preserve that one function that they have. But I get also very disturbed by the healthy 15-year-old that has a focal lesion that maybe we could rid them of their seizures, but they incur some kind of dependency. I'm happy to hear your thoughts later on that. The other 2 points are simply from that the patient who swallows. There's paradoxes we have sometimes that empathy in the rare cases will make things worse. And certainly the final thing, I push hard back against, we have nothing more to offer, so let's try this even though I don't have a good hypothesis. That just isn't a good reason. We need better reasons than that. Okay, so we're near the end there. As I said, I'm nervous, so I always have a ton of other cases that we could talk about. But I think I'm going to stop there and see if there's any last questions or comments. I think we're close to the hour.
You know that last slide where you wondering if you could say more about
The nothing else left, so we might as well try trap. I think this is a pretty profound trap that a lot of specialties get into, so I'm curious about if you could say more about that.
Yeah, so for instance, think about the stereotactic EEG. There was a epilepsy conference recently, a Toronto physician had one line to say is, don't go fishing, right? To justify the risk of a surgery, you need some reasonable hypothesis, because just injuring someone with a hope that maybe you'll find something that you're guessing isn't enough, right? Sometimes, what field are you in? Your social work, but bone marrow transplant. Yeah. So yeah, I've seen some kids with graft versus host disease. It's just been terrible. I'm sorry, they're burn victims. Some of them, the one case in particular, I think is a great example of that. You look back at the records and a well-meaning team said, well, there's nothing else to save their life, so why don't we just try? And it was, from the outset, the numbers were all wrong. They didn't fit the criteria, but they wanted to give a heroic try, and that kid's life was made worse. It just was, it's heartbreaking for me to think back in the PICU.
And I guess I'm curious, in your work,
How much do you find that you're addressing sort of that moral injury or moral residue of the provider? Because I think the nothing else left, so we might as well try, really comes from a lot of pain that providers have, especially if they're dealing in either refractory illnesses or high mortality rates. And I'm just curious, from your role, like, how do you hold space with a provider who is hurting, and so they're just going to pull the one thing left out of the bag?
So, I part of what we do as ethics consultation, I hope that we lay a foundation on which patients, families, and providers can heal some of those things. So trying to find the right thing at that moment to help them understand all they've done. Bob's there in palliative medicine, so I often borrow from palliative medicine the idea that where can we focus the hope now? Right? And so that works with patients, but it also works with providers. Listen, you've done an amazing job, and what is it that we can now hope for this next step. And then for the patient who took their own life, it was meaningful for us to have that M&M to that surgeon, because then they wanted to bring out what can we learn that maybe we should be more attentive, maybe we should have a social worker. And I have a wonderful nursing ethics colleague, Georgina Morley, who does a lot in the area of moral distress and residue and these kind of things. She takes it a step farther of wanting to, even after the fact, to do some moral debriefs and other things that, in my mind, go beyond what ethics, the minimum ethics consult. At minimum, I want ethics consults to say the things that allow our providers to refocus and get the help they want. But I think it's a good thing when programs also provide that additional space afterwards, after the acute time. So I think that's a good that she does, and others to call it moral distress, residue. There's lots of different words, and she'll get angry at me because she knows the differences between these things. But for me, it is, how can we help them heal and give them the space to do that so that they can get to the next patient? Right. Are we out of time? Thank you very much for your attention. I appreciate it.
Thank you, everyone, for attending this session. Thank you, Paul, for a great talk. Our next talk, as part of the OBHC series, will be a virtual talk by Dr. Chris Feutner. He's the chief of the Division of General Pediatrics at the Children's Hospital of Philadelphia. He's going to be talking on fostering collaborative relationships between patients, families, and care teams. Thank you. Okay.